So this has been a recent interest of mine from the standpoint of, I think, collaboration, but also thinking about, again, the whole cat and how we think about targeted therapy for our various patients. So obviously I'm coming from a kidney-centric world. Our son is kind of kidney-shaped, if you will. But we do realize, as we just alluded to, that so many other disease processes and so many other organs interplay with these disease processes. So that's where I really want to present this concept of how things are related. So in the outline of my presentation, we'll talk a little bit about definitions for constipation, thinking about how constipation would be assessed in our feline patients, then delve into the cool science, where do we get nerdy about different pathophysiology of constipation and kidney disease and how they play together with gut health, and then of course target some treatment strategies. How are we at this point in time addressing this for our feline patients? And so part of what I want to allude to here is really proactive management as well. So most of us will recognize that obstipation is the cat that we don't want to see, right? We have intractable constipation, and I would ideally like to identify the cat that's constipated subtly or clinically or subclinically, before we get to the point of obstipation, because then we have chronic colon damage that we actually have very little that we can do about. And when we look at the definitions of constipation on the human side, it's very interesting that it's actually defined two different ways, which to me mean two very different things. So you have infrequent or difficulty evacuation of feces. So having difficulty passing stool or passing fewer than 3 stools a week. But those are pretty different. So you might actually have decreased frequency, and then that might be a little bit challenging to identify, whereas if there's actually trouble with the defecation process, that might be more apparent. And then, of course, the fecal score is very important as well. So when it comes to thinking about our feline patients, we've really kind of started to think about this a little bit more, and this concept of what subclinically might be occurring and how quickly and how proactively can I be about assessing constipation. Really what we normally would see would be the obvious signs. A client actually bringing a cat in to say they're straining or vocalizing or even vomiting in the litter box while trying to defecate. That's really, that's something that someone's going to notice. However, that could be going on when they're actually not noticing it, or they might not offer that information to you during the medical assessment. So we should ask those questions as well when we ask about litter box health. But more importantly, especially with kidney disease, I'm looking for more subtle signs that there might be a problem with constipation and there might be a problem with hard stools and frequency of defecation. So thinking about actually showing that client a fecal score chart and having them identify what they're seeing in the litter box. Thinking about when you do your physical exam, palpating the colon, what do I actually feel in that? Is there a normal compressible stool? Do we have small, hard little pellets? Do we have large amounts of feces that's very hard? That's what you don't want to feel on physical exam, right? And then this concept of decreased frequency, which can be a little bit hard to get at if folks really aren't aware about what's going on in the litter box and maybe they're not the best at scooping them. And then last but not least, a lot of people may be familiar with the pooplet phenomenon. So this little thing happens where you find little pooplets around the house, and of course you tend to step on them accidentally, right? So many people can probably identify, yeah, I see people nodding their heads. So this implies to me that there's been a problem in the litter box and then the cat has been trying, and for whatever reason then they give up, and then boop, the pooplet happens someplace else in the house. To me, if I hear that, that's another sign, and that hard, small, dry feces, that's another sign that we might have a subtle problem, that even without the straining and the vocalization and the difficulty, we really need to look into that a little bit more for that patient. And in general, when we consider constipation, I'm looking for an underlying disease process. Yes, we do have syndromes where we have probably dysfunction of the colon, especially in younger patients, and they seem to get to the obstipation and the megacolon quite quickly. But especially in the elderly patient, there's almost always an underlying condition that we need to figure out what that is. And of course, in my world, that would be chronic kidney disease, so we think about that quite a bit. But there's many other contributors. You can have constipation as a form of gastrointestinal disease as well, right? What about that elderly cat that has osteoarthritis? What about medications that contribute? What about environmental stressors? Again, I'm going to speak to this memo concept for the cats as well. We, of course, want to do some diagnostics to know what we're getting into and really think about what's happening with these patients. So I would like to make sure that I have done a workup to determine what diseases might I be able to easily identify. And of course, again, being kidney disease oriented, where might we be in that process? We've certainly even seen it with hyperthyroidism or anything else that's going wrong with that cat where their litter box habits might be affected. It's a really important way to look at it. Why would their routines not be normal? Why might they have cause to have a change in GI motility or a change in their litter box habits that might result in constipation? Some imaging is also really nice. I honestly would like to know the flavor of the constipation that I'm getting myself into. So here, we have the typical, this we might see with chronic kidneys, small, hard pellets that are kind of built up before the pelvic inlet. And then we also have cases where we have a much larger fecal mass that we have to deal with. And those, I think, are important distinctions because it might help me choose what therapeutic route I'm going to go down. Also, it's not just the feces that I'm evaluating, but I'm evaluating the rear end of that cat as well. And so here we have 2 cats with chronic kidney disease, both who have a decent fecal burden, but you can also look at the lumbosacral area. This cat doesn't seem to have any issues along the lumbosacral area. This cat has pretty significant LS disease, and that, for whatever reason, is really important for the feline patient. They just seem to need to be in the right position to get the job done. And when they have LS disease, it can really affect their habits. It can really affect their ability to have that position in the litter box and to effectively evacuate the colon. So I'm very much looking for those signs as well. Of course, I can feel on my physical exam what's in that colon, but I may not be able to evaluate the rest of the colon and see how much of a fecal burden there actually is. Give me a little bit more information about how much that cat is actually, they are defecating daily, but they are defecating enough daily, is really the question that we have to ask there. And then lastly, I would like to point out that it's not just about the diagnostics. It is really also the whole cat picture. So this is just a case example to point that out. This is a little milk carton, aptly named by his young people in the household because he's white. Milk carton doesn't like us very much, unfortunately. He's a very stressed kitty to come into the house, and he has a history of house soiling, extreme anxiety in the clinic, and using some feline-friendly handling and a little bit of gabapentin, we were able to make his visits as good as they could be. He loves to hide under the blanket. Unfortunately, he's also challenging to medicate. And therefore, we were dismayed to find that his chronic kidney disease was relatively late stage at the time. He was in poor body condition, poor muscle mass. He was dehydrated, constipated, hypertensive, hypokalemic, and hyperphosphatemic. So there's some work to be done here. So from a medical standpoint, I really feel like I have things that I can do for him, and we have a couple of different treatments that we elected to do. We needed to get him started on appetite stimulant. We needed to address his hypertension. We needed to address the hypokalemia and also think about the standpoint of a hydration supplement. And so I'm discharging this cat, and I bring him into the room in his carrier. And 3 tiny little exuberant girls run to greet him, and they go, "Milky!" And the cat visibly cringes. And I thought, And I said, "Can you tell me just a little bit more about where Milky hangs out in the household and where his litter boxes are?" Because, of course, I had approached the scenario from a chronic kidney disease standpoint and wasn't thinking memo at this point in time. And this case has changed my strategies because the owner said, "Well, he lives in my husband's closet." And I went, "Oh, and where are his litter boxes?" "Well, they're downstairs," right? So I thought, oh, okay, well, we need to provide him better resources. So part of our plan was moving water, food, and litter closer to the preferred area that he liked to stay in and institute some off-limit rules for the girls. Like when Milky's in the closet and he doesn't want to be bothered, we're not going to remove him from the closet. He needs to have his resources. And much to my surprise, this cat actually did way better better than I would have thought. He was better hydrated, he was defecating and using the litter box, which was now closer to his favorite closet, and he actually gained a pound of weight, and his creatinine improved. His kidney disease actually stabilized more in the IRIS stage 2 range, and he lived for several years beyond that point when I first saw him. And truthfully, although I prescribed him a bunch of medications, by the next summer he really didn't need them anymore, and I feel honestly like the main thing I did for this cat was put his litter box near the closet. And he did a lot better. So he's just kind of that message that we really do need to think about, again, the environment and an individualized plan for these cats. Again, what can we do to get them in the litter box more frequently in a comfortable way when constipation is something that we're struggling with? So with that, though, I do want to think about, like, well, how do we go from the colon here to the kidney? What's the interplay between the two? As we think a little bit more about the relationship between kidney disease and constipation. And happily for me, there has been some additional information that's come out into the literature that I think is really helpful for defining this. So this is something that we kind of know as practitioners, but I was delighted to see this study that indicates for us that yes, cats with kidney disease are more likely to present to the emergency room for episodes of constipation. And when I say episodes of constipation, I mean that overt constipation, the one where the caregiver is actually seeing the cat in the box, having an issue, and then they take them into the vet because defecation is not happening, the animal is uncomfortable. And so to follow up a little bit more on that, we became more interested in thinking about more subclinical constipation, the concept of decreased frequency, not just now it's a medical emergency and care is needed. So we did a defecation survey study to try to start to get a look at this. And with the concept, based on some previous studies that owners don't really have a great idea of what's going on in the litter box, we elected to do a survey where it was an interactive survey, if you will. We asked folks to scoop the box once a day and report on a daily basis what they found in the box. Like very simple, like 2 urine cups I found today, a defecation, like 2 defecations, what did I find? We tried to pick households that had a relatively smaller number of cats, or they had to be households where the caregiver felt they really could differentiate. And some people, again, cat owners, they're like, well, Fluffy's, always goes in this box, or this cat's, poop is this size, like I can tell them apart. So these are the folks that we had in this survey. And interestingly enough, that data showed us that there was a decreased defecation frequency in chronic kidney disease patients. So normal cats in this survey defecated about 1 to 2 times per day, and cats with chronic kidney disease, as reported by their caregivers, of course, defecated every other day to daily. So this was our first evidence that actually, even before someone thought there was a problem, we were seeing a decreased frequency. And we've now followed this up with an additional study using litter box monitors to try to look for more objective information about this to say, can we substantiate the evidence that we collected with the survey? And in fact, this was a summer student project that we did last summer. It'll be presented at ACVM this year as an abstract. So we enrolled healthy cats, screened them, chronic kidney disease, screened them. Everybody was stable. And importantly, these were cats that the caregiver would tell you didn't really have any problems in the litter box. They didn't have a history of constipation. They weren't on Miralax or anything else like that. And we set them up with a litter box monitor for 30 days of, once the monitor was optimized, we collected 30 days of data. And we actually did see that those CKD cats, again, had significantly more days without defecation than normal cats. So we looked at 2 weeks, 3 weeks, and 4 weeks. And the longer you went, the more obvious difference between the groups there was. And even a week in, you could start to see this differentiation. And it wasn't actually the number of times that they visited the box that was interesting. It was the number of times that they didn't defecate that was missing. So that was interesting. So they're missing on a regular basis, even going to the box on certain days to defecate. And so that's our decreased frequency that starts to look a lot like those human definitions of constipation, only going 3 times a week. And this is what that outread data actually looks like when you're comparing normal cats and chronic kidney disease cats. So Gus, he's a super pooper. He's a normal cat. He's going every day like clockwork, no matter what. And that's one of the things we've really amusingly learned from these litter box monitors is the routines and the habits that cats have. And then Kitty, she's a cat with stage 2, stage 3 chronic kidney disease, and she is not going on a regular basis. There are many days, like about a third of the time, maybe even half the time sometimes, when she's not going to the box. And there's no straining here, there's no difficulty. She just doesn't get up off the couch that day and go have a defecation movement. So it is really interesting that, again, they don't think that they're struggling, but again, their frequency is definitely decreased. So this has been a valuable tool for us, and we are now launching into a number of prospective studies. Of course, the next question is, well, what can I do to help out, right? So now I can intervene now that I have some objective monitoring. So actually, for the purposes of this particular presentation, I attempted to collect some intervention data to show you. This is my cat, Dinah. She's actually about a 7-year-old female spayed domestic shorthair. And I would grade her fecal scores as a little on the hard dry side for no particular reason. She actually gets hydration supplement. I can't find anything wrong with her. But in general, her fecal scores are not what I would like them to be. So I thought, okay, very clever. She's set up with her device. I'm going to institute a diet change and see if I can improve her defecation frequency and her fecal score. And this was right before I was about to leave for MAF grant reviews, and so I set her up with a diet transition. I gave my husband the plan. She really liked the food, and she dove into the food, and he was like, oh, she really likes the food. So I'm out of town, and I check my app, and I'm like, what is happening on January 8th and 9th? She's gone to the box many, many times, which she never does. And so I text my husband, could you please go, go through here on the 9th. She's defecated now 4 times. What is going on in the litter box? And he says, oh, yeah, she's having diarrhea. I'm like, okay, well, please stop the new diet. Thank you very much. So what are the 2 things we learned here was it can be helpful to monitor your litter boxes. And remember that whole thing about transitioning diets slowly? Yes, you should do that. So in an effort to improve her fecal score, I gave her diarrhea, but the app let me know that that was happening, and we were able to stop that diet that she clearly didn't do well with and go back and come up with a new plan. So again, we're very excited now to be able to use this technology both from a client perspective and from a research perspective to really teach us more. Now I feel like we've gotten to the point where, hey, I really have a tool that I can use that we can answer a lot of questions that we have about this disease process. But when I think about what's happening in chronic kidney disease, I have to ask myself, well, what are the contributing factors? What else do we need to know? And of course, kidneys, when the kidney is broken, we are not concentrating urine the way that we normally would, and it's primarily a water balance issue, right? So they're dehydrated, you're now pulling water out of the colon, and for a variety of reasons related to motility, you actually have a slow transit problem in kidney disease. So on the human side, they define the types of constipation as slow transit or other types of problems. There's multiple reasons that I'll show you in a minute to have decreased GI motility associated with chronic kidney disease. Then you add on things like hypokalemia, phosphate binders, and then the uremic toxins and the gut-kidney axis really become important here when we're talking about constipation. So now we'll transition to that part. So there's many, many reasons why you could be struggling with constipation or that subclinical decreased frequency in chronic kidney disease. What about this interplay between the gut and the kidney? Well, there's certainly a huge body of literature out there now. There's less when it comes to constipation, but there's these really intriguing glimpses that I want to share with you. And one of the big things, I was very excited to hear about the intestinal barrier earlier today because it absolutely applies to kidney disease too. There's some older studies that show that this is part of where the gut-kidney axis comes from, that you have your normal intestinal barrier, but in chronic kidney disease, uremic toxins actually have a negative effect on those tight junctions. And so we talked about having this one layer of cells as protecting the lumen from the rest of the body, and those tight junctions being so key. Well, when it comes to these uremic toxins and other aspects that are abnormal in kidney disease, you have great disruption of that. And you have a leaky gut, again, and then the interplay between the two. So we'll talk about how uremic toxins build up in kidney disease, and again, how they can exacerbate the health of the intestinal barrier. And I think that's a huge problem. We hope to be able to define that better specifically in chronic kidney disease cats, but it's been shown in various other species. What we do know at this time is that cats with kidney disease do have dysbiosis, associated dysbiosis. So, and this is characterized by decreased microbial diversity and richness, and at the same time we have increased uremic toxins that are building up for a variety of reasons. So when it comes to thinking about uremic toxins, we'll just define those for a moment. Any substance that can accumulate with decreased GFR is basically considered a uremic toxin. And when we talk about markers that we normally look at clinically, creatinine and BUN are uremic toxins, but they're really just the tip of the iceberg in terms of things that you potentially would say would be a uremic toxin. There's a society of uremic toxins, and there's about 146 uremic toxins that have been identified. Most of them actually have a lot of deleterious effects, and that's where we start to get quite interested. One in particular that has gotten a lot of press is indoxyl sulfate, and I've been going to American Society of Nephrology meetings. I remember the very first time I went, I was incredibly impressed by the number of posters in this gigantic poster hall that dealt with uremic toxins and indoxyl sulfate, and I realized we really hadn't characterized this on the veterinary side at all. The important thing about uremic toxins, specifically indoxyl sulfate, is it is produced in the colon. Again, this is a story about the colon and constipation as a result of protein fermentation. And unfortunately, its production is increased as a result of gut dysbiosis. You're unfortunately selecting for an overpopulation of bacteria that might be indole producing and leading to the production of this uremic toxin. So when we look at that in a diagram form, we have dietary proteins, they're going into the colon. When we're talking specifically about indoxyl sulfate, tryptophan is being made by the bacterial, made into indoles by the bacteria in the colon. That indole is then absorbed into the body, and in the liver, it's made into indoxyl sulfate. And then the problem, of course, is that that should be renally excreted, and it is not. So then you start to get buildup of those uremic toxins, and they then begin to feed back upon the gut. The gut is being, dysbiosis is occurring, and you're getting even more production, and again, your vicious cycle results from that. We know that uremic toxins increase with iris stage, but interestingly to me, we even saw that in earlier stage cats. So I don't honestly think a lot of times we give CKD stage 2 cats enough credit for being ill. When I was in vet school, we typically said, oh, they're not clinically affected by their disease stage. There is a lot going on for these cats. They are losing weight. They are losing muscle mass. They're starting to struggle with their appetite. They have uremic toxins. I bet you they have issues with their gut permeability, again, already at this stage. And when we start to think about the negative effects of those uremic toxins, the list is very, very long. So I'm not going to go into this in detail, but I like to put everything on one slide just to show you how many things there are. And some of these review studies, there's entire reviews on all of these different deleterious processes, direct kidney effects, CKD, MBD effects, muscle effects, effects on EPO, affecting anemia. Every aspect, uremic toxins has its fingers in, just like a little octopus, okay, right? So like everywhere, I read a study and I'm like, oh, the uremic toxins again, having a deleterious effect. So we really want to think about that, and of course, it's no surprise then that there is a relationship with constipation. This has not been studied as much, but there is some really interesting research out there, and it does turn out that in humans with chronic kidney disease, when they have a lower stool score, that they have higher uremic toxins. So p-cressyl sulfate is one in particular that has been shown to be associated with a more suboptimal stool score. And then additionally, branched-chain fatty acids is another area of really interesting research. So isovaleric acid in particular causes relaxation of colonic smooth muscle. So we talk about the uremic toxins, but we also want to spend a little bit of time talking about things like those branched-chain fatty acids, because they're kind of like the Jekyll and Hyde, if you will, of the short-chain fatty acids. So it was really interesting to me. We have had a lot of discussion about short-chain fatty acids and the beneficial effects of fiber fermentation. So that's on the left-hand side. All of these good things come from that. So anti-inflammatory, again, colonic motility. It's going to help that mucin layer in the intestine. But the other side of that is the branched-chain fatty acids that come from a result of, again, protein fermentation. We have isovaleric acid and isobutyric acid, which are promoting inflammation and have a negative effect on GI motility. So what's the relevance to that in our veterinary patients? Of course, that's not something I'm clinically thinking about. We did actually look at that as part of Dr. Stacy Summers' work, and looking at the correlation of these fecal fatty acid concentrations with the other uremic toxins. We were looking again for evidence of like this deficiency in straight chain fatty acids like is seen on the human side, and what's happening with branched chain fatty acids. Interestingly enough, we didn't actually see a decrease in those beneficial straight-chain fatty acids. It's very different than what they see on the human side, and maybe that's a difference in the diets. Maybe we're doing a better job with the diets we've created for these patients in terms of supplementing them there. In humans, a lot of it is related to a decrease in fruits and vegetables, again, alluding to what we heard earlier today, because many of them are high in potassium, and people really struggle with hyperkalemia on the human side, and so they're often told, you can't have bananas, et cetera, because they're higher in potassium. So that might be where some of that is being driven. Interestingly, though, so we weren't able to provide any additional information on the straight-chain fatty acid side, but the branched-chain fatty acid side really turned out to be a bit more intriguing than we were expecting. We did find increased branched-chain fatty acids in feline chronic kidney disease, and specifically that isovaleric acid, the one that has been associated with decreased GI motility, was quite high in cats with kidney disease. Now, this is a typical cat graph. There's always going to be one cat not following the rules, right? So whenever you have an outlier in your data, you should always ask, why is that happening? And even when we remove that cat, we do have significance. We have higher isovaleric acid. But that cat was actually eating a raw diet, which we didn't realize at the time of enrollment. It never really, I just didn't pick up on it. So we collected samples from bets of cats with chronic kidney disease, and then looking back, we realized, oh, her diet was actually drastically different from all the other cats, and she had sky-high isovaleric acid. So that's an N of 1. I don't truly know the implications of that, but we do have this tie-in with isovaleric acid, and we do worry about that as one of these drivers when it comes to what's happening with GI motility in these patients. And then more recently, we've actually, due to, I would say, the passion of Janessa Winston for bile acids, we have been looking at bile acids in kidney disease as well. So thinking about the concept of how this might play into this disease process, again, what's happening in the gut? How does it affect my organ of interest? So in the gut, of course, primary bile acids are altered into secondary bile acids by the gut microbiota. And those secondary bile acids play a role in gut motility. So we had decided to look at this, and then just recently I realized what the implications of this might be for GI motility as well. So when it comes to bile acid dysmetabolism, dysbiosis is associated with bile acid dysmetabolism, and decreased secondary bile acids are associated with constipation. There's actually several studies about that. So we know that cats with chronic kidney disease do actually have decreased secondary bile acids, and specifically UDCA is decreased in cats with kidney disease. We had an ASAIM abstract about that a couple of years ago, and now they're starting to delve a little bit more. We've now done a deeper analysis that will come out this year, looking more specifically about the microbial community that's associated with that. But very interestingly, there are actually interventional studies on the human side and on the rodent side that look at this aspect from a pathophysiologic standpoint in terms of actually treating GI motility. So when you treat with a bile acid transport inhibitor in humans, it actually can improve constipation and fecal score and increase those colonic secondary bile acids. So again, we're looking for therapeutic targets, and when we think more about the pathophysiology, the more we learn about this interconnection between the gut and the kidney, we really are discovering that there are targets on the gut side that might really help us out, and specifically those related to constipation. So that's pretty exciting for us. That will be a future area of research as well, for sure. So then let's take a moment then to talk about the constipation as a therapeutic target. Where are we going there? And so again, as I mentioned, hydration is a huge part of this. Hypokalemia is a huge part of this. And I think it's very important, I mentioned so many disease processes are associated with constipation. Again, I really do want to have an idea of which disease process are we talking about. If we're talking about kidney disease, I do have really specific goals for where I want that hydration and that potassium to be. I'm going to try to get that potassium into the normal range. I'm going to try to make sure that constipated patient is as hydrated as possible. That will be an important treatment goal for me before I potentially might be reaching for other things. Of course, osteoarthritis is a big part of it, addressing, like I mentioned, that discomfort during defecation. Bunny, this little guy, this was his Christmas outfit. So Bunny actually had really bad LS, arthritis, and when we addressed that for him, his defecation frequency, based on the owner's observations, were improved. So on an individual basis, again, we want to create that patient plan. Fiber is another area where we do have to say, is this appropriate for this cat? What types of fiber? What does that diet look like for them? In general, I'm not a nutritionist, I'm going to generalize a fiber comment by saying it's trickier for kidney disease because of the other things that I think are involved. But of course, we want to make sure that we're providing that substrate for the reasons that I already mentioned. It does tend to be a little bit trial and error in our experience, and especially if you're already having a hydration problem, pouring on large amounts of fiber might not be your best strategy, right? You really do need water to go along with that fiber. So we want to make sure that we're thinking about that holistically for them. That also would be true for the osmotic stool softeners. Of course, I use things like osmotic stool softeners in my patients to manage them. But again, if you've given that Miralax or that lactulose and they're not hydrated, remember what those agents are doing is they're pulling water into the colon. So you're stealing water from the rest of that dehydrated patient to put it in that colon and hydrate that feces. So I'm trying to make sure that my overall water balance is corrected as I'm going forward with that treatment strategy. And then last but not least, especially depending on the duration of the issues, is do we need a pro-motility agent like cisapride in order to help out these patients? So again, we have a very staged approach. It depends very much on the underlying condition for that specific cat in terms of where we might be going. When it comes to thinking about hydration, I will target that a little bit just from the kidney disease side being so important. What are all of our strategies? Well, we certainly can feed more of a canned diet instead of a dry diet. Lots of people say, well, we get this question a lot, does canned food prevent chronic kidney disease? We do not, of course, know that to be true at this point in time. Cats will be cats, and they may not want to eat a canned diet. And the other thing that we really struggle with, especially when they have a compromised appetite, is actually getting enough calories in when they're eating only a canned diet. So although I would love that from the standpoint of hydration, often we struggle, and we often need a little bit of calorically, compact kibble to make sure that we're meeting our caloric goals. But, from the hydration standpoint, we do try to introduce that element of canned food. We can add water to food. Some cats do not fall from that strategy at all. They think, what have you done to my food? Special attention to water sources is also very important. The concept of clean water, what does that mean? Does it mean you're actually rinsing out the bowl and replacing it every day, or just adding more water to dust bunnies in the bowl? Or do you have a fountain that is not cleaned frequently enough? So A lot of people think water fountains are great, but they're not great when all the cat hair in the household is now in the water fountain. No cat probably is going to want to drink that. So really making sure that you have paid special attention to those water sources and where they are in the household. Again, if the cat is living in the closet upstairs and his water bowl is downstairs, that's not going to be a successful hydration strategy, right? And then, of course, we have nutrient-enriched water as well. Again, like HydroCare, some cats really like this and it can be part of their hydration strategy. Often we're doing multiple things. Some of them get sub-Q fluids. Some days they get HydroCare. Some days they have water in the food. Anything that you can do to promote that hydration is really helpful. We've always, promoted sub-Q fluids, but I still have a lot of questions about sub-Q fluids, especially when it comes to the sodium load that goes with them. And we talked about, RAS activation. Nobody knows the answer to that question. But in general, we do seem to clinically and anecdotally feel that when cats get subcutaneous fluids, it helps with their constipation, it helps with their hydration, and most caregivers will tell you they feel like their cat feels better the day after they have gotten subcutaneous fluids. So for some people and cats who will allow them to get sub-Q fluids, that can be a helpful strategy. So it's something that we do really focus on. The big comment that I would make there is that people often ask me this question, well, what stage do you start hydration therapy, or what stage do you start sub-Q fluids? It's not a stage. Once again, it's an individual cat decision. Do we have a problem with constipation? Do we have a problem with hydration? I'm not treating a number, I'm treating the cat. I'm assessing that cat's hydration strategy and employing a hydration management plan for them. That's really the most important way, I think, of looking at it. And then lastly, I just want to spend a little bit of time talking again about targeting those uremic toxins. So we are, especially when we're thinking about constipation and this load of material that we might have in the colon, maybe we're having increased uptake of uremic toxins with that feces sitting there. What can we do to decrease that load of uremic toxins, especially if they're having that cyclic effect of decreasing GI motility? So we can talk about dietary modification, fiber, prebiotics, probiotics, absorbents. Honestly, I think there's so much research in this area because it is a problem for all species. These uremic toxins are poorly cleared by conventional dialysis, so they're a problem for everyone. And realistically, that's probably what's driven this research on the human side in all of these rodent models. When it comes to dietary modification, this really was a big part of, from my estimation, like not being an earlier generation of nephrologists, this is where a lot of the dietary strategies came from in terms of decreasing that protein load in later stage disease to, again, try to prevent the uptake and production of these toxins. Unfortunately, I think the story is a lot more complicated than that, and I think we have a lot of research to do in terms of an optimal strategy for diets. What is an optimal protein concentration for the cat? What does that mean in terms of the colon? What is the effect of constipation? There's a lot of different areas to go there, and it's probably a bit more complex than we've given it credit for. So to date, we still don't have really, really targeted evidence in the late stage cat that especially severe protein restriction is going to help with uremic toxins and then also still keep them in good muscle condition. There's a bit of a balance between those two things that can be quite complex, especially when you take into account the fact that the gut is unhealthy, they're not absorbing nutrients the way that they should, and we have all of this dysbiosis occurring. So lots of opportunity here. Again, watch that space. It's been something that's been actively studied recently. The last piece that I want to leave you with in terms of thinking about uremic toxins would be another strategy of actually trying to prevent them from being absorbed into the body. So there are some absorbents that have classically been available, products internationally and now here in the US and other countries. So these absorbents tend to be carbon-based, and basically they're pulling uremic toxins into tiny pores within the substance, and they have an electron charge that also facilitates binding. And the idea here when you're thinking about the gut in general is that, again, we have nutrients coming in. You have these amino acids that are being digested by the intestinal bacteria into these precursors of uremic toxins. They're then absorbed into the body, but you're using these absorbents to block that process from happening. So that's going to decrease the workload on the kidney because hopefully we won't be getting that level of concentration in the serum needing to be excreted by the kidney. So again, stopping that process in the gut. Again, the gut being a therapeutic target. And then I sincerely worry, and something that we're working on measuring is what's the uremic toxin burden then in that constipated kidney cat? We know that chronic kidney disease by itself increases uremic toxins, but they could be even higher in that constipated patient. So in that line, there's now been several studies that are underway. We have a couple of absorbent studies underway, and there was one that has just come out of the University of Munich group. So they looked at stage 2 and stage 3 chronic kidney disease cats and looked at this absorbent, and they did see a decrease in uremic toxins. They actually saw the fecal dysbiosis index changed as well, and they did a more long-term study that showed some beneficial effects. We've also looked at it with Dr. Lenko at UGA, and we also have a clinical trial as well. So far, all of the preliminary data that we've seen is very encouraging in terms of using absorbents to decrease those uremic toxins. So in closing, what I want to bring around to the end of the presentation here is that this concept of toxins is very much tied to the colon. The concept, of course, of the colon is tied to constipation, and that's where we're really getting the meld between the gut and the kidney. So we do think the gut and the microbiome and all of the constipation that's in association with kidney disease is a therapeutic target. We have multiple ways now that we could be addressing that, and lots of future research to get a better idea. We're really excited about this area of research. So we have a bunch of strong collaborations going on and a bunch of really great ideas where we could go forward and really hone treatment strategies. Based on the evidence that's out there, this seems to be a really important area. So thank you so much for your attention. I appreciate it. It's a pleasure to be here.